IVM.
$100. That's all it takes to begin your journey with Bitcoin and Ethereum. No, really. With CoinSwitch, you can start investing in over 100 cryptocurrencies with just 100 rupees. On top of that, there are zero charges for deposits and withdrawals, so you can trade, buy, sell, however and whenever you want. All of this, plus their extremely intuitive interface, makes CoinSwitch the perfect app for beginners in the crypto space. But don't take my word for it. Just download CoinSwitch for free and try it out for yourself. If you'd like more information on cryptocurrencies, tune into A Show About Crypto with me, Rohan Joshi, my new adventure on IVM Podcasts. CoinSwitch, kuch to badlega.
Hey guys, welcome to Simplified. This is Chuck. If you remember last week, we were speaking to Dr. Nitin on a whole bunch of things related to how the virus has affected the medical fraternity and just so much more. The conversation was so awesome and we went off into so many different directions that we actually decided to split it up into two different episodes because it went on for so long. So here it is. Here is the second part of this two-part interview. If you haven't heard that interview yet, if you haven't heard the first part yet, I'd highly recommend you go back and listen to it and then come back to this one. So if you have heard it, then on we go then. Here is the Simplified gang with Dr. Nitin.
Yeah, but then on those lines, Doc, are there like from an intensive care unit, intensive care purpose? Because the other thing is this as well, where I don't know. My father is notoriously a man of very few words, very very converse to my own nature. But so he's been. I mean, he's had his own issues with health and all that stuff, and he's had several visits to the doctor, and he's had several. A couple of hospitalizations, including a couple of ICU visits and stuff. And I have always asked him about his experience in the ICU and stuff like that. So there was one anecdote that came across to me, which made a lot of sense. So what happened was when in the same time when he was in the isolation ward in the isolation ICU for swine flu, we were all terrified because my father has diabetes and asthma. So it was a really, really dangerous kind of context. But he had, funnily enough, he had not, thankfully he was started on Tamiflu earlier. So he had not developed any symptoms. He had not developed a fever, any of that stuff. He was just in isolation. The one thing that he kept saying all the time in isolation ICU was that he was bored. He was very bored. And he was so bored that he was like, I can't do anything. I am not. And my father also is a very particular, very neat man. He likes to shave every morning and he couldn't shave. They wouldn't bring him any stuff inside. So he was like developing a beard and he was very annoyed with that. So the one thing that I managed to do was I managed to tip a few ward boys and get like the test match going. There was a test match going on at that time, test match going on the TV inside the ICU. Yeah. And that tremendously improved my father's spirits there. So I have seen this one thing about like how raising people's spirits generally has a massively positive impact on their health, right? And so what's your perspective from an ICU point of view and whether how that has made a major difference?
Without doubt. So basically, one of the things, about 10, 12 years ago, we had a patient who got better, went home, and then they came back for a visit, and he said he was massively bored. And he said, why don't you have radios in every room?
Because the decibel meters go off.
No, sorry, no, I know. But during the day, when the patient's awake, they can choose what to listen to. They can choose what music they want to listen to. And this is before, we had Web 3.0 or Web 2.5, whatever you say. Yeah. So, fine. So we said, well, sorry, there's no funding for it. We would need lots and lots, and we would need ones with a remote, and we would need ones with digital radio because the UK was switching over in 3 years' time. We didn't want to keep having to buy new ones. And about 6 months after that, they come back with a huge package containing 25 radios. So they donated radios. Another family then donated 5 television sets. And on any given day, it is unlikely that I will have more than 5 patients in my ICU who are awake and well enough to watch telly. So Now, yes, a lot of our patients have televisions that are mounted on a portable wheels, stand with wheels, and we wheel it out to the bed space. We give them headphones, and we have started giving up noise cancelling headphones to our awake patients anyway, so they can sleep better at night. So they get a choice of earplugs or noise cancelling headphones, and they get eye masks. So basically, it's like being in business class in an airline.
Oh, nice!
Not quite.
Amazing how much what level of sensitivity to patient well-being you have in the UK. We have nothing. I mean, it's just terrible.
It's actually it's very Maslow's hierarchy, right? Like there's. I mean, we are here to keep your body alive, and we will manage. We will succeed in that mission. The rest is your problem.
No, it is. They were so before before hygiene became a thing, and so there was this guy who had to go around telling surgeons to wash their hands before operating because it just wasn't there, and people would wear their aprons blood spattered as a thing of pride, because that would show how successful, how popular they are. Similarly, here in ICUs, the doctors tend to be, so I'm just extrapolating from the one experience I've had of ICUs when my father was in there. They are incredible. They wear their insensitivity like a badge.
Wow.
So this is I it's just one sample, one ICU. So I don't know if I'm fair to extrapolate that, but somehow I feel it is. So what would it take to have that level of sensitivity, to come here?
Okay. How much do you want me to digress?
Oh, please, just whatever.
Okay. I have no idea what the agenda of this.
But I am fully on board here. So go on.
Yeah.
Naren just said stories and a freewheeling chat, but whatever. And I said whatever. As long as you allow, as long as you allow me to get one or two nudge stories in. We'll do
100%.
So
100%,
and we've already got the sound nudge story, so I'm happy. And I don't know if you want patient anecdotes. I can give you a million. But let's come back to this one. Okay, so without meaning to sound derogatory towards India in any way, and I lived for 29 years in India before I came here. India, our society there is no nice way of putting this, brutal. So Three Idiots, Veeru Sahasrabodhe in the first scene says, life is a race and life begins with murder. And Veeru actually is not that far wrong. And so basically there is so much brutal competition everywhere. And what happens is there is pressure to differentiate into science, and oh no, if you are bright, you will go into science. You can do you can do pre-medical, you can do pre-engineering, but you will go into science. There is no option. What happens there is from standard 5 onwards, no one gives a shit about the social sciences.
True.
And we are taught that this is soft stuff. Then you get further on, competition is so brutal. Over here, if we get 90 applicants for 20 registrar positions, it's like the competition is brutal. I'm like, guys, you don't know what competition is. When we have our pre-medical test, it is 500 to 1. There is so much competition that you basically, again, going back, if I remember, I think this is in Three Idiots. I can't remember what film it is in. At one point he says कि अच्छा डॉक्टर बनने के लिए अपने अंदर के इंसान को दबाना पड़ता है. क्यों? Because I think this is Munna Bhai. क्यों? Because when I was in India, in a typical 8-hour day, if I was in outpatients department, I would see 70 patients, 60 patients, sometimes 80 patients. Okay, and realistically, you're spending 6 hours there because at the start and at the end, you spend an hour on the ward doing a ward round. So you have 6 hours to see 80 patients. In that time, You're also going to discuss something with your boss. You're going to send people to have an ECG. They will come back with the ECG. So effectively, you're doing about 120 patient encounters in 6 hours. 6 hours, 360 minutes. 3 minutes.
3 minutes per person.
3 minutes,
Okay.
Wow.
Can you listen to the patient's story,
Literally
make a
no.
diagnosis,
Yeah.
and write things out in 3 minutes? No.
Literally
And-
no. Yeah.
Okay, even if you have 5 minutes, can you then provide, because the doctor's job is not just diagnosis, it is also reassurance and understanding. So telling the patient what is wrong and what they need to do and how they need to do it. But if you have 3 minutes per patient, what are you going to do? So at some point, you start thinking, am I doing the right thing by these patients? And I again experienced this during the first wave of COVID, where we had, normally we have a consultant to patient ratio of 12:1. So I will typically spend 30 to 40 minutes with every patient every day.
Oh, wow.
So that's 6 hours, and normally I work for 10. And then we will, do a little bit of teaching, and then we'll talk to families, and we talk to our families every day, not me personally, but one of the doctors will talk to families. And before COVID, we were a 24/7 open visiting unit. So you would sit with families so that, if a week later someone's dying, actually the family are not angry with you. They will not come and beat you up, because they have been there for 4 hours a day, and they have been seeing how you guys have been battling to keep their loved ones alive, and they can see as the number of machines by the bedside grows that they are getting closer and closer to death. And it's the sort of soft skill that we do not emphasize. I'm probably painting it with very broad brush strokes.
Yeah.
But this is my personal view, and which is that we do not emphasize the soft skills enough. And this is, for example, all this business about, this may be slightly controversial, but anyway, I'll get it off my chest. In 1990, you guys won't remember, Naren will, when the Mandal Commission thing was there.
Yeah.
And this is, I'm not proud of this, but I was one of the people holding up placards and marching, because it was a case of, fine, why reservations, give everyone free education, and we do not recognize privilege when we see it.
True.
Yeah.
It's taken me years to recognize that, yes, we were not rich, but my parents were doctors. I had access to books. I went to a CBSE English medium school. I made friends with the librarian, so I was allowed to borrow 2 books every day. So I wouldn't do my homework. I would just sit all evening and read books. And we know that there was never any worry about, are we going to have food tomorrow? Got a Vespa at the age of 18, but it doesn't feel like privilege, because all your friends are in the same position.
They're in the same thing. Yeah.
And we know, even in this country, that the number one, then, if I remember correctly, one study, at least one really large study, says that the number one determinant of school performance at the age of 8 or 10 is, did your parents read to you, or did they give you access to books?
Right.
Wow.
Because if you are already reading, or if you are used to being told stories by the time you're 3 or 4, you're going to have a much easier time in school, aren't you?
Yeah.
And so you are going to always stay a step ahead.
Yeah.
So, and this is privilege.
Yeah.
And we don't always recognize the privilege.
Yeah, we don't. That's it's only just being recognized, and it's good to see that there is so much, debate, and people come out, right? So that even that is good. People come out with guns blazing that, this is nonsense and reservation is bullshit and so on. And then other people call them out on it, and a discussion develops. And I would like to think that many people get a sense of what privilege actually is. So
absolutely. Because just yesterday we were having this discussion. I try and stay out of these. But in my old medical college class group, there was this discussion about reservations. A lot of people were like, no, all reservations should be stopped. Or at least once they have got into MBBS or engineering college, after that, there should be no reservation. What the hell are you talking about? You're talking about someone, okay, your parents started teaching you ABC when you were 18 months old, so that you could crack the 2-year interview at the prestigious school. You are talking about, and from there on, your privilege continued. You went to coaching classes, expensive ones, all that stuff. And then you're saying, oh yeah, give everyone free education. Fine, but free equitable education. Because you have someone else who's going to a Punjabi or a Marathi medium school where their first experience of writing A is when they are 11 or 12. How do you expect someone whose whole life has been spent speaking English with someone who has 5 years of education in English, but the exams are all set in English? The medium of instruction is English. It's a foreign language to them. Some of them will succeed. You will always get an Ambedkar. But look at the privilege.
Yeah. I mean, that's what, right? The barrier of, I mean, that's the Ambedkar example is, especially it's used so often in this privilege conversation and like, but Ambedkar did it despite everything. Yes. Yeah. I mean, the point is there are always going to be either genius level or tremendously enterprising people who will overcome all odds and get to a certain point. That does not mean that, oh, now everyone should be able to do it. They are by definition an exception to the rule. Yeah. The whole point is to
using the exceptions as the norm is a mistake.
Yeah, that is the classic this thing. But actually, winding back to the earlier point that you were making about the point about I lost my train of thought just now. But the aspect of you were saying about doctors.
About
doctors not having enough
time.
Time aspect of things. Like I know this like just now where I was in Malaysia. I was in Malaysia till recently, and I just returned to India, and there we had an intern who had come to work with us. She was just recently. She was like a final year college student in Malaysia, and she was talking about she was just enamored by the fact that I had done my MBA, and I was like, it's not really that spectacular because like doing your post graduation and doing an MBA in Malaysia is a much bigger deal than it is in India. So she was like, can you please tell me about how you did your MBA? And I was like, okay, so this was this. I gave an entrance exam and all that. And then she's like, no, 1 second. What's an entrance exam?
Wow.
And I'm like, entrance exam? I was like, yeah. I was like, did you give an entrance exam to get into college? She's like, no. You choose which college you want to go to. You apply to the college. You go to the college. You pay the fees and you go. I'm like, are we even the same species at this point?
Exactly.
I mean, Indian life is defined by entrance exams from when you are like a 2-year-old.
Yeah.
So I mean that was one point, and the second point you said about the doctors, and I have a personal experience about this with a doctor who's again one of the experiences of treating my father. Now this guy is our family doctor who's been treating us for like many years, and despite being our family doctor, he's an amazing doctor who has consistently maintained an extremely brusque and business-like 3-minute bedside manner for entirety of our association. We've been getting treated with him by him for 25 years, and he's always maintained the same bedside manner, and we're used to it now. But we know he's a good doctor. So the thing was, he was training my dad through some stuff, and then my dad had like some complications and stuff, and he actually was coming to, so my dad was in the hospital, he was coming to see my dad, and I was fully ready, like I'm used to the doctor, so I have written down notes. I know I have a 3-minute window while I can get everything in, so I have notes down and I'm ready with all the stuff that I need to talk to him about. And then he walks in and he goes and he's like, how is your dad? And I'm like, huh? What question is this? This is not on the syllabus. This is not what I expected of you. And then he was kind of like shaken up because he thought my dad was in a very serious position then, and he kind of thought that this man who I've been treating for 25 years could no longer be. And it kind of shook him up. And then afterwards he pulled himself together and he almost looked annoyed with himself that how did he allow for emotion to come in at this particular point in time. And
wow.
And I was like, oh my God, like what an existence, what is this existence of a doctor that, yes, I understand that you get close to your patients, but if you treat someone for 25 years and you can't not get at least somewhat attached to that, right? Like there is an attachment there, and the system of ours, this Indian system, by definition prescribes that you should not be attached to your patients because they are 3-minute windows on your life.
Unfortunately, yes. We were taught in medical school not to get emotional. We were taught not to not try and personalize patients. So what you try and do is you just try and depersonalize them. The problem is, and again, this is not meant as a criticism. This is just what I feel used to happen. And I don't work in India at the moment, and I have no idea of the Indian health system in the last 16 or 17 years, apart from the couple of times that my family have been unwell. And that is a different story, because I know by definition I'm going to get better treatment, or my family going to get better treatment and especially better communication than anyone else. Because, my mother's doctor was 1 year junior to me in college. So we just chatted on WhatsApp video rather than me having to wait for him. So it's a different story. Yeah. But the problem is, you're taught to depersonalize. What happens is, where does the border between depersonalization and dehumanization start? Yeah. And I think that border is that boundary is very wide. So there is a big space there between the two in the private setup, and there is a much smaller space between the two in the government setup. And part of that is because the healthcare system exists to provide, to tick the box of providing health programs rather than necessarily treating everyone, because there are no performance related reviews. No one cares if you get a complaint. Yeah. So there's and there's this whole thing with that I am a Sarkari officer. So basically you are all inferior to me. Because we always say government servant. We never ever seem to say public servant.
Yeah.
Wow. Well said. Yeah, that was heavy.
Sorry.
No.
Yeah. So, but also another thing. So, and finally, just to wrap it up, I think the final question I'll ask is: we talked about entertainment for the patients, right? Yes. And during the first wave and continuing over 2020, we saw a whole bunch of videos coming out where doctors in full PPE doing dancing and relieving their stress in various wards around and doing all kinds of crazy stuff. Like, because I mean, obviously it was a hard time and they really needed like their entertainment element in their life back. And this actually reminded me a little bit of I used to play this game called Sims at one point in time, and Sims is all about like, it's basically you're living a person's life. So you get them to like eat, drink, go to the toilet, go to work, find a job, all of those things. And there were all these different meters of their life below, like these all markers. Like there's an energy bar. So if the energy bar ever went to zero, they just collapse and pass out somewhere, right? But then there were different bars there, and so there was one bar called fun. And so that fun required to like, you had to go and play a game and stuff like that. So if the fun bar went to zero, the guy would just go in a corner, sit on a chair and for hours just cry. Right. And then you couldn't do anything then. Like you could not use him for about 4 hours or whatever. So it kind of gave me, it brought back the memory of that game back to me, where I was like, in this kind of context where you're running 20-hour shifts and all you're seeing is death and deterioration all around you, your fun bar really has to be in the toilet then, right? Like you are not having, there is no space for fun in life at all. So in that level, and I know obviously during COVID, it became a much more exacerbated thing, but on a general level, in such a high stress, high intensity, such a serious environment, how is the fun quotient of ICU doctors come in, and how do they replenish? How do you guys replenish yourself?
Okay, one, can I say that at least in the UK, I'm not aware of even one ICU TikTok video. However, there were lots of TikTok videos from surgical wards. Huge numbers. Because basically what happened was medicine, emergency medicine and intensive care were really busy. We stopped operating because there was no staff. So surgical wards, a lot of staff there didn't have enough work to do because we were still doing emergency surgery, but not enough work there. Some theaters, not enough work. So basically, staff are there. It is a stressful time in the world. They want to have a bit of fun. Why not?
Right.
Yeah, I don't see a major problem with that. And actually, if we had time in ICU, if people wanted to do some filming in the corridor or something, why not? What's wrong with that? But yes, it was hard. And one of our recent surveys showed that after many years of decline, after decades of decline, the number of ICU staff who say who drink or smoke has gone up in the last 2 years.
Oh.
So it has been stressful. And yes, as you said, there hasn't been enough credits in the fun bar. So it's been replaced with let's do the other stuff bar, which is rather sad. And another of our surveys showed that about 50% plus of ICU doctors and over 60% of ICU nurses are rate pretty high on burnout scores. So it's not fantastic. So yes, the bar is steadily going into the red, and at some point it may go down to 0, and then we will need a break.
Wow.
So what do you personally? People have hobbies outside of work, and they kind of stick to that. But so, in your workplace environment, to keep a more lively and upbeat environment, personally or within your colleagues or among your patients, what is your approach to it, or what is the approach that you've seen that you really like?
So the key is to keep it light. In old-fashioned English, we used to call it banter. So the problem is you have to be very, very, very careful. Especially as an older male, you have to be very, very careful because, again, I'm going to get some hate for this, but it is so easy for a joke to land wrong. It is so easy to fall foul, for a joke to be non-PC. If you're working with a team that is really well known to you, fine. If you're working with new people who don't know you, it can land wrong and it can get you into serious trouble.
Right.
So, yes, it gets slightly difficult. But the approach generally is to stay with everyone as members of a team. One of the things that helps is when I was young, the consultant was this godlike figure. The nurses were not even allowed to speak to the consultant. Only the ward sister could speak to the consultant. The junior residents weren't allowed to speak to the boss on the ward round. Only the senior residents could. So only the senior resident would give the report. It's very different. We are a very flat hierarchy, or we try and get it as flat as possible. Someone still has to make the final decision. We are very much a first names only unit. And if a student nurse, as you're at the patient's bedside, a student nurse asks you why there's no question that everyone is absolutely allowed and encouraged to say why. And we think that this is like the famous Toyota factory, where it is a case of they don't have quality inspectors because every worker is expected to be a quality inspector, and every single worker has the authority to stop the assembly line at any point if they see a defective part. We try and do the same thing. So you can have a student nurse who will stop a 55-year-old consultant who's been doing medicine twice as long as she's been alive to ask why they just did what they did, why they've prescribed what they've prescribed. And it is expected that you or one of your colleagues will spend a couple of minutes explaining what you've done, and then offer to explain further later in the day. So we can now continue with patient care, but later in the day we will come back. We will either talk to you, or we will send you a link to a review article or something somewhere of teaching. And I think that helps with the camaraderie within the team. So your team, because otherwise it can get very lonely. You can just think it's just me because I'm the senior person here, so you can't talk to anyone else. But actually, being roughly equal members of a team allows you to then take the next step and show a little bit of vulnerability. And actually, again, this is the I had to work a lot for a long time to get this barrier out of my head, which is in India, age is equated to wisdom. वो बड़े हैं, वो बोल रहे हैं, उनकी बात सुनो. Who the fuck said that? I have seen plenty of 60-year-old idiots, and I've seen plenty of 30-year-olds who are very wise. So,
very true.
Your junior doctors may be junior to you in medicine.
Age.
But they are respectable human beings in their own right, who may be very sensible and may actually be able to help you. They may have things to teach you, and they may be able, actually, they may be more emotionally mature than you. They may be able to sit there and talk with you.
Yeah.
So remember, and it's the same with your nursing staff, because you cannot treat them as junior members of the team. They are senior professionals. You talk to your nursing staff, and experienced nurses who have done ICU for 20 years, they will stop you making mistakes, and they will also come and talk to you sometimes about, because if you and the nurse at the bedside, you've gone to speak to a family, you've had a difficult discussion, at the end, you spend 5 minutes talking about it, just let it out. It works. Occasionally, venting works. Now, one of the best things we did many years ago was one of the only good things about WhatsApp is our consultant-only group, which we call the ICU group therapy. And basically, that is, you're allowed to vent, and you're allowed to say whatever you want. And it is basically, you can't read it out on a family channel.
Yeah. Omerta applies, so no one sort of shares it with anyone.
Yes.
And so you get your sailor time, like you talk like a truck driver or a sailor.
Yes, without doubt.
What happens in ICU therapy stays in ICU therapy.
Yes, absolutely.
This is,
yes.
Yeah.
Right. How many film references
this is so
have we had?
fascinating. It's like, Huh? How many?
Sorry, I was just saying, in this recording, how many film references have we had?
I mean, I never thought I'd be referencing Munna Bhai at any point in time, but yeah.
Yeah, 3 days
so
is pretty standard, isn't it?
Yeah, it is, yeah. No, but this is so fascinating. Like in the last episode, we just spoke so much about, the last time we recorded, Doctor, we just spoke so much about COVID, ICU, etc. Here it's almost like we have looked at the humans making this happen in some ways, their problems, their fears, at whichever level it is, right? We started off talking about how this whole wave is impacting junior doctors. Srikeit's first question about how this is going to impact the current generation of MBBS students or whatever the equivalent around the world is. And this sort of like ending poignantly enough with a senior doctor's WhatsApp group where everyone is allowed to vent, and it's almost like that's acting as therapy in some way as well. So it's quite fascinating across the board. No, that was just an observation. I don't have a question really.
So should we wrap? I think we've gone well over.
I think we should. I think
this has been a great chat. I mean, I think, Doc, we could just talk to you for hours and hours. I think. I think we.
I'm very. So here's the thing. There are several other questions, and I'm very sure, Doctor, this is not the last time you're going to be asked to wake up at 5 a.m. and do a recording. But what I find heartening is that I don't think we used the O word even once throughout this conversation. I think that's how the entire thought of getting you back on once more was, but we never discussed the wave and all that, which in a way I guess is good, but yeah, I mean, it's interesting now that these kind of conversations are happening, now that things are, in some sense, I'd like to say getting back to normal, but it's good that these conversations are happening. These problems are coming out of the surface, so at least we can work for solutions for them in the future. And
the thing is that the human approach, right? So it's very tempting to be awfully technical about everything, right? And you almost certainly cannot get more technical than an ICU, because you have all that equipment, you have a million parameters that you have to take care of, and it's somebody's life at stake, everything. And then to be human in the middle of all that, all the technical things. That was, and so I'm seeing a universality here. So it's ICU and being human in an ICU setting is, if you can be human in an ICU setting, you can probably be human in all settings. So I think people should look at their own workspaces, their own family spaces, and whatever spaces they are
and interacting with absolutely, you can extrapolate that. That's a beautiful way of thinking, Naren. It's like you can extract this to anything, right? Like if you are yelling at a customer care executive, remember that there's a human at the end of that. If there's there's any business, no matter how much artificial intelligence and all that, how many lines of codes are there are humans at the end of it, and that means both the negative and positive sides of things. So absolutely.
That's
simple. You know how to. I know how you're going to wrap this episode up.
But I think all in a day's work. I think Doc, you've pretty much cured Naren of his COVID. Also, he looks like much more. He looks so much more full of life right now than he did when we began.
I was miserable last night, and I'm feeling so much better now. Yeah.
Okay.
And if anyone's listening to this who happens to have COVID, if you manage to cure that, please let us know, because then we will apply for WHO emergency emergency status, and it'll be amazing if the WHO says all you need to solve COVID is listening to Simblified. So hopefully in a ICU ward in Birmingham somewhere, you'll have Simblified blaring through the speakers, because that's the only thing that is allowed to cross the decibel level. I pray for that.
But although, Doctor, I must, in true Indian fashion, admonish you, we've been recording for about 90 minutes and you could have seen about 30 patients in this time.
Not me. It will be two. I'm slow.
Thank you so much, Doctor, once again. Your years of this, I mean, we can just go on talking again and again, but thank you so much for spending this time with us, waking up.
I'm pretty sure we'll be getting you back again soon.
We'll be here.
Thank you.
And to discuss another aspect of this thing, hopefully not another variant, please.
No.
But,
Definitely not another variant.
We're sick of this now.
I would like to sign off by saying that, stay safe, everyone, and stay human, and stay simplified.
Hey everybody, it's been another great week on the IBM Podcast Network. On Storytellers and Storysellers, Vineet talks to founders Dinesh and Vivek about the path-breaking changes their AR edugaming startup PlayShifu has brought about. On Think Fast, Varun and Suchita talk to communications consultant Karthik Srinivasan. He shares his insights on brand stories, woke culture, and regional content. On Cyrus Says, a cock and bull episode with ex-producers Naveen Arora and Abbas Momin. Cyrus asked if they ever participated in a fancy dress competition. On All Things Policy, the Takshashila Institute folks discuss the importance of digital equity in achieving true progress. And on Probation Se Promotion Tak, Abhinav gives us tips to be mindful of before seeking a mentor. Also, just one quick announcement for everybody. We would like you to check out the new version of our Android app. It's available on the Play Store. It's a really interesting take on how to listen to podcasts. Do give it a look and let us know what you think. We're open to feedback on all of our social media channels. We're IBM Podcasts on Twitter, Facebook, Instagram, and LinkedIn. Also, do remember, if you're enjoying this show or any of our other shows for that matter, please do tell a friend. Word of mouth really does help. And don't forget to rate us on any of the platforms you're listening to us on. And you can also check us out on YouTube. And we have a number of channels there at ivmpodcast.com/YouTube where you can take a look at them. And finally, we'd like to thank our sponsors this week, Bank of Baroda and CoinSwitch Kuber. Thank you so much for making this possible.
Namaste, this is Cyrus Brocha. I am part of the government cancel culture program to remove rubbish off all the different streams available. So what we have is all the collected rubbish we put together on our show. It's called Cyrus Says. It's on IVM Podcast. You have to watch it and listen to it. It's on our app. It's on our website. It's on the YouTube channel. It's on Facebook. There are many different ways. Don't bother me and ask me how. You have to find out. We talk to different personalities. Many of them are known. Some are just people we meet downstairs and invite them up for chai. But the point is, it's fun and it's very therapeutic. So please join in and listen to Cyrus Says.